So first of all, thank you Goodfellow for asking me to talk on the topic of the postpartum pelvic floor and the role of pessaries for uterine prolapse. So I'm going to start with the postpartum pelvic floor and particularly vaginal delivery, which is probably one of the biggest events a pelvic floor muscle will experience, whereby it has to stretch 1.5 to 3 times its natural length to allow a baby's head to come through. And we know for about 10 to 30% of women this will result in irreversible overdistension or avulsion, where that pelvic floor muscle tears off its attachment of the pubic bone, which markedly weakens the pelvic floor muscle, but also significantly contributes to the likelihood of pelvic organ prolapse development or recurrent prolapse post-prolapse surgery. We know that perineal trauma is really common, with about 1 to 6% of women sustaining trauma into the anal sphincter complex. And we also know that women will also potentially sustain acute trauma to the vaginal fascia causing prolapse. The pudendal nerves can undergo de-innervation, re-innervation, as well as bony trauma, which, as you can imagine, can all significantly contribute to the psychosocial well-being of women, especially at a time where there are so many other factors colliding together to make up the postpartum experience. We also know there's not great health-seeking behaviours for pelvic floor disorders for lots of reasons, although I'm really optimistic that this is going to change with the current ACC changes that are about to go through in October, which I'll talk briefly about in a second. And so I think one really important thing that us as healthcare professionals can do is just ask, so just where we can, screening women around their birth and whether there were any kind of negative or psychological trauma around it. Urinary symptoms, obviously incontinence is really common in the postpartum period. Bowel symptoms, again constipation is quite common, but anal incontinence, super distressing and an easy place where we can intervene. Prolapse symptoms, vaginal bulging, dragging, heaviness, and sexual dysfunction, again quite common. I don't think women are particularly forthcoming with this, and again there's lots that we can do. So I'm going to go through an objective assessment of a pelvic floor, and obviously when women come to see us as physios, we're looking at them more globally in terms of breathing, posture, abdominal wall. But I thought an objective assessment is quite useful because I know with the ACC changes it will be based on, the reg codes are based on objective assessments. So obviously when we're looking at a pelvic floor, we're first looking at just sensation. We're looking at tears, how well healed they are, how flexible they are, how they tolerate kind of pressure. Looking at the perineal body, a really important structure in pelvic organ support, in pelvic floor support. So not only its length, but also where it sits in space. So obviously at rest, lying down, we want that perineal body to sit at the level of the ischial tuberosities or just above. What happens when they contract? Does that perineal body lift up? What happens when they bear down? How much does it bear down? And is there too much distensibility? What happens when they cough? What happens when they maybe do an abdominal curl? Just to have a look at that overall pelvic organ support. And then taking a measure, which I'm going to talk about here. So I talked before about that 10 to 30% will sustain that irreversible overdistension, and how that's measured in research or clinically is with ultrasound, 3D ultrasound, and you're looking at the levator hiatus area. And so a group of researchers had a look, well, how can we do this clinically without an ultrasound, and actually a measure from the urethra to the perineal body, to the anus, so including the genital hiatus and the perineal body, was shown to correlate with that hiatal area on ultrasound, which is super useful. And what we know from research is that a length of about 7 centimetres or less is considered normal healthy support. But once we start going above 7 centimetres, we're starting to get what we call mild marked or severe hiatal ballooning. And this is significantly correlated with the likelihood of pelvic organ prolapse, which is a really important measure if we've got someone who might not be symptomatic or might have mild symptoms, but they're about to go, maybe they're keen to go back to CrossFit, or they're keen to go back to high impact exercise or a job that involves heavy lifting, and it gives us a bit of a risk factor to whether they might be more likely to develop prolapse. Obviously, when you have a prolapse sitting in the level of the pelvic floor, that in itself will create a little bit of increased distensibility. And I thought I'd just share this study by Handa et al. In 2019 was a prospective study looking at women who had no prolapse symptoms, and they've just measured their genital hiatus, and they had a significant difference between the group that go on to develop prolapse with a mean genital hiatus of 3.16 and they also, their genital hiatus increased at a faster rate. So they're just helpful measures for us to go, how do we advise these women? In terms of, we're obviously also going to look at the pelvic floor muscles. So, so looking at the outside pelvic floor muscles, so the anal sphincter, if there's any indication of anal incontinence, the bulbospongiosus, so the muscle at the vaginal entrance, if there's any indication of dyspareunia, or urinary incontinence that might be related to the pudendal nerve. Doing a POP-Q assessment, so having a look at their vaginal walls in relation to where they sit on Valsalva to the hymenal ring. And then looking at the deep pelvic floor muscles. So I talked before about levator avulsion, and how you'd measure that is just going either side of the urethral meatus with your finger just on the back of the pubic bone and getting that woman to contract their pelvic floor muscle, and you'll feel the bulk of that muscle if it's intact at the side of your finger. And it's often really obvious if it's a unilateral, because you go to the other side and you might not feel any muscle for a while. Which is, it's important to know, one, for ACC now, it looks like, but also if that person was going to be considering prolapse surgery, or around their rehab expectations, or around how they're going to use their body in terms of intra-abdominal pressure. One thing I would say though, from my experience, is how we deliver that information to a patient obviously has to be really considered, given it can be quite a grieving process to recognise you've sustained trauma that might not be reversible. And then just looking at your general pelvic floor muscle health, is it happy to be kind of with pressure, or is there lots of discomfort there? Obviously not all postpartum pelvic floor muscles are weak. Sometimes these women are really gripping on because of maybe the trauma of the birth, or hemorrhoids, or fissures, or pain, or the sensation of prolapse or incontinence. And then looking at how well that muscle contracts, how it relaxes, and how it performs with pressure, so like a cough, a sneeze, an abdominal curl, or a simulated defecation. So that's a quick overview of the pelvic floor assessment. And then in terms of physio treatment, there's obviously a broad scope that we can work with, and it really just depends on where women are at and what they can cope in terms of the timing. And so sometimes it can just be really basic stuff around lifestyle modifications and fluid management techniques, toileting techniques. Obviously we do lots of work in terms of pelvic floor muscle rehabilitation, and then I'm going to talk to Pessaries in a second. There is really good research for physio in the incontinence and prolapse space, so I'll just put that in there. So the great news is that postpartum pelvic floor injuries will be covered by ACC. So it means that when you're asking these questions, you at least know that you can refer them on. And if you go to the ACC website, they've got all of the red codes they're covering, and it's like all perineal tears, prolapses. Obviously, like incontinence or anal incontinence aren't covered, so that's why I said they need some degree of objective measure. And probably the only thing I'd say about this is just patients, when they're navigating the physio space, might think they can go see their ankle physio or their shoulder physio, but they're obviously going to need to see someone who's got some knowledge in the pelvic health space. But this is great news.
And is that historical or just from...
No, not historical, so only new, I know. Uterine prolapses. I'm going to talk about pessaries, but basically in terms of uterine prolapse, you can still use the same for anterior wall. Posterior wall are the tricky ones. If any of you are new to pessaries or just beginning the journey, I'd strongly recommend you read these UK clinical guidelines. They're fantastic. They're a collaborative effort of their urogyne group, their continence group, their physios, their nurses. They are really well done, super simple to follow, and really good resources around types of pessaries, handouts, lots of stuff. They've made a clinical pathway, which I'm not going to go through, but basically it's screening kind of your suitability for a pessary, and basically everyone's suitable unless there's some really obvious contraindications, and then right through to follow-up. In terms of like choosing your patients for pessaries, like I said, if there's no contraindications, the general consensus is that we should be offering conservative therapy to all women. And I thought I'd just highlight this. So I'm sure we've all had patients talk to us about the pessary that got fitted and it fell out at the car park. And there have been lots of studies that have had a look at risk factors for pessary success. And I thought I'd just highlight prior hysterectomy and previous prolapse surgery. So this is, I think, where getting in early and trying conservative measures is so important, because often once you've had surgery, you might have less success. And I just thought I'd also highlight self-management of pessaries improves success and patient experience. And so as a physio, I'm really big on getting patients to take their pessaries out themselves. But we do know that it does improve their long-term use with the pessary, so it's worth it. There are two types of pessaries. There's support pessaries. Support pessaries rely on a degree of pelvic floor muscle, like as a shelf, which is where if you've got someone who's got a bilateral avulsion, you might find a support pessary just falls out. They're much easier to put in and take out, and you can have penetrative sex with them. A space-occupying pessary doesn't rely on that levator shelf, so it can be quite good if there's a little bit of poor muscle bulk. They're more difficult to put in and out, and you obviously can't have penetrative sex with them. In terms of choice, and so again they've created this algorithm to choose, really the big questions are they sexually active? In which case they either need to use a support pessary, or if they're willing to self-manage, they can obviously try a space-occupying pessary. So the easiest types of pessaries to use are a ring pessary. I didn't realise it was such a big group, but I put some in. Ring pessaries are really easy to fit, and if you can fit a ring but it's falling out and that's all you've got, you can always put 2 ring pessaries in, like a smaller one and then a larger one. Or if you're keen to try, you can use a dish which has a bit more suction, and that's the one on the left, or you can use a Schatz pessary, which is a bit harder. But you can always just start with a ring and see, because that will give you a bit of a sizing guide as well. In terms of how to fit a ring pessary, I'll quickly talk you through it, but again, you can find this on those guidelines. You fit a ring pessary at the top of the vagina, so you go right to the top or to the vault, you take your fingers as wide as you can, and then you'd pick a ring that's just 1 finger breadth smaller than your width. You obviously also need to check the length of the vagina, and so women who have obviously had hysterectomies where they've got a shortened vagina, you get in a bit more trouble there because their width is slightly more than their length, and you can there are oval pessaries, you can have a play with those. And then in terms of fitting your pessary, you just fold it in half really. This one's a really big one to show you, and just insert it in. It sits above the pubic bone, and you just want to check you can get half a finger each side, and just get them to cough, sneeze, bear down, check that it's not slipping below the pubic bone, get them up, do a squat, maybe go check that they can do a wee. And then I always get my patients then to take it out themselves, and if it's great, I'll teach them how to put it back in and then send them off. So super easy. And this is great as well. I haven't used it, but it's a new, I don't know if it's new, but it's a device to help you get the pessary out. So for some women who want to self-manage, but it's just too far to reach, you can get this little tool to help. So space-occupying pessaries can be great for women where a ring just falls out. It's clearly not going to provide support. I don't have much experience with donuts or inflatables, so that's the inflatable there, but they can be a really good option, and I know my colleagues in Australia are all over this space and using lots of different types of pessaries. An inflatable pessary, at least you can self-manage, because you can put it in, inflate it, deflate it, take it out. But I'm going to talk to you about a cube pessary, which again is a really good option. I use them in my kind of postpartum space. It has suction on all sides, so it means that it can suction to the vaginal wall, and so you don't need much pelvic organ support. To fit a cube, I've been taught to size it at the entrance, so you'd go to the vaginal entrance, you'd take your fingers side to side, and then you'd see how many fingers you can get in there. So let's say 4, then you go anterior to posterior, so urethra to pubic bone. Let's say you get 3 fingers, you take the smallest size, 3 minus 1, and that would give you a size 2 cube. And then to fit it, you just put it between your thumb and middle finger, use your index finger just to hold that front wall down. And it's just a matter of squishing it in and just protecting the urethra really, because it's a pretty clunky shape. And then pushing it up, sometimes it suctions on the way up, so you just need to break the suction and push it back up. Get them to do a few squeezes to get the suction, because otherwise you'll hear it gurgle, and then Again, do a few sit-ups, cough, sneeze, get them up, squat, make sure they can do a wee. The key with a cube, though, is they need to be able to take them out themselves. In theory, they're supposed to come out every night, and so in clinic I would teach them and the way you take a cube out. So if any of you are keen to use a cube, just try one on yourself, because then you've had that little bit of experience. I know that, see, us physios, that's how we train, but for you guys that might be a bit novel. So to get it out, you just have to break the suction and pull the string, and break the suction and pull the string, and break the suction and pull the string. So it can be a bit of a process, but women do get much better at this over time. And so yes, and I just thought I'd highlight, the cube got a bit of a bad rap, but that was from a study where it was just a neglected pessary, where it got left in for 10 years and it caused a fistula. They're supposed to come out every night, and this study followed women over 5 years, and it had a really high long-term use rate, 81.5%, which is much higher than most of the pessary studies, and very minimal side effect, apart from you do often get increased discharge with them. And because of the suction, you can get a bit of bleeding. But what was really exciting was their average pessary size reduced from a size 3 to size 2, so that distensibility was getting a little bit smaller. And then a Gellhorn. So Gellhorns are great. I actually haven't used one on a patient. I've used them on a few physios, but they scare me a bit, but they're really good, and I know lots of my physio colleagues in Australia are using them, and some in New Zealand. You size them a little bit smaller than a ring, so generally 1 to 2 sizes smaller. This one's quite a big one, but you basically just fold it in half, you part the labia, and you just put it on a 45-degree angle away from the urethra, spin it in, and push it up. They're really good, again, for a woman where a ring just seems to not manage it, and it just pushes down. They can just be a bit trickier to remove, so that's where I've been a bit nervous. But again, this study I found in 2019 got the physio to fit everyone with the Gellhorn and teach the patient or the family member or a healthcare, someone, a healthcare assistant, to remove them, and had 62% still using it 1 year, so that's pretty hopeful. There is a cross-reference sheet, so if you've got rings and you're used to rings, you can then go, I'll use my ring to help me decide what other pessary I might use. And then in terms of follow-up, if the patient's not self-managing, in theory they're supposed to have a speculum exam and a kind of removal, clean, put back in every 3 to 6 months. If they're self-managing, that can be annually. Obviously, there's still research in this space around what's the long-term kind of best management. I think it's just really important that women get good instructions on what to look for complications, how to, what to do if they have any concerns, and then good handouts, which again are available on that that clinical document. And then there is a kind of push that we all start documenting the pessaries we're using and our success, so that we can, if we needed to, do a big audit on that space. And there's some references if you want them.